Welcome to the FINE Lecture Series. On behalf of the Perinatology Research Branch of NICHD and the National Institutes of Health, my name is Lami Yo, and I am one of the developers of FINE. In this lecture, we will review characteristics of the 9 diagnostic planes of the fetal heart, which are automatically generated by FINE. As a reminder, after the stick volume has been determined to be appropriate using stick loop, the next step is to mark anatomical structures of the fetal heart within the stick volume using the anatomic box tool, and once marking is completed, this triggers intelligent navigation technology. By identification and selection of key anatomical landmarks, the system will generate a geometrical reconstruction or model of the organ of interest, such as the fetal heart, and then automatically navigate, find, extract, and display specific planes, in this case, 9 standard fetal echocardiography views for the FINE method. Here is an artistic representation of intelligent navigation of the fetal heart. 7 structures are marked by the user in sequence. Next, an internal geometrical model of the fetal heart is generated, and then the system will automatically navigate through the model, find, extract, and display specific cardiac planes, such as the 4-chamber view, the aortic arch, 3 vessels and trachea view, and the ductal arch. 4 planes are shown here, but of course FINE will depict 9 planes. We refer to the 9 fetal echocardiography views automatically generated and displayed by FINE as diagnostic planes, and they are the 4-chamber view, 5-chamber, left ventricular outflow tract, short axis view of the great vessels, right ventricular outflow tract, 3 vessels and trachea view, abdomen, stomach, ductal arch, aortic arch, and superior and inferior vena cava. Here are the 9 fetal cardiac views in motion displayed together in a single template for a normal fetal heart. This video shows the entire marking procedure and generation of diagnostic cardiac planes. First, the aorta at the level of the stomach is marked. Next, the aorta at the 4-chamber view, crux, right atrial wall. Next is the pulmonary valve, superior vena cava, and the last point to be marked is the transverse aortic arch. Within several seconds after marking this point, the 9 cardiac diagnostic planes are automatically generated and displayed by the FINE method in a single template. Now we will review 5 distinct characteristics of the diagnostic planes of the fetal heart generated by the FINE method. The planes are displayed together in a single template. They can be viewed in motion or as still images. There is automatic reorientation and standardization of the anatomical position. The cardiac diagnostic planes are 4-dimensional images, and successful display of cardiac diagnostic planes occurs despite different gestational ages and anatomic variability. First, we will discuss how the diagnostic planes are displayed in a single template. FINE will automatically and immediately rotate, align, dissect, and scale the stick volume dataset to display 9 cardiac diagnostic planes simultaneously in a single template. It is important to point out that both transverse and sagittal images are shown at the same time. Therefore, fine is not equivalent to what is known as tomographic ultrasound imaging or multi-slice imaging. They are completely different from each other. Tomographic ultrasound imaging or multi-slice imaging is applied to sonographic volume data sets and can only show slices that are parallel and equidistant to each other. The overview image in the red circle indicates the position at which 8 slices are cut parallel and equidistant from each other. The 8 vertical lines are separated by an equal distance, 2.9 millimeters in this example. The user can adjust the number of slices and the distance between them. Each vertical white line corresponds with a particular slice, which is transverse in this case. This is the first slice, the second, and the third slice. However, fine never generates fetal cardiac views that are parallel or equidistant to each other. In addition, because only a single overview image is equidistantly sliced, transverse and sagittal planes can never be shown at the same time by tomographic ultrasound imaging or multi-slice imaging. It can only be transverse or sagittal images. For example, the ductal arch is being sliced here, and therefore only transverse planes are shown. In this example, the overview image, which is the 4-chamber view, is being sliced, so only sagittal planes are being shown by tomographic ultrasound imaging or multi-slice imaging. In contrast, fine never generates slices through the fetal heart that are parallel and equidistantly spaced to each other. Instead, fine generates and displays 9 cardiac views, all of which completely differ from each other in distance, angle, and rotation. As you can see, both transverse and sagittal cardiac planes are displayed at the same time. Cardiac diagnostic planes can also be viewed in motion or as still images. Here are the diagnostic planes in motion. And here they are as still images. The third characteristic of the cardiac diagnostic planes is that through intelligent navigation technology, FINE performs automatic realignment of stick or spatiotemporal image correlation volumes, as well as reorientation and standardization of the anatomical position. Specifically, the fetus and diagnostic planes are consistently displayed in the same manner each time, regardless of the fetal position or initial orientation. This allows fetal structures, anatomy, and relationships to be more easily recognized as normal or abnormal. Why does FINE do this? Because interpretation of our world often depends on visual pattern recognition. Here is a historical example that demonstrates this concept. This train from 1918 shows various strangers sitting in the train car. If one of the passengers was holding the New York Times and another passenger directly across from him was trying to read the folded headlines, this would be very difficult because the headlines are upside down. There are 2 solutions then for the second passenger. Either train him to read the newspaper upside down all the time, or take the newspaper and turn it right side up so that the headlines are now at the top of the page. It is now very easy to read the headlines in 1918, which announces the end of World War I. Indeed, even smart devices, such as the tablet shown here, will automatically rotate the actual screen when the tablet is turned sideways. So in this case, the same lotus flower image is shown regardless of how the tablet is rotated. The same principle of visual pattern recognition applies to sonographic images in which our interpretation of such images depends on the fetal position, as shown here, which completely varies in the maternal uterus. Now here is a symmetrical organ, the fetal brain, which is ball-like. Therefore, regardless of different fetal positions in the uterus, it is straightforward to interpret transverse views of the fetal head as shown here. In contrast, here is the fetal heart, which is a complex and asymmetrical organ. It is well known that adequate sonographic examination of the fetal heart depends on fetal position. For example, on the left is a two-dimensional ultrasound image of the fetal heart in which the fetus is in breech presentation and the spine is located at 10 o'clock. The image on the right is the identical image, but in a fetus that is in a vertex presentation with the spine at 6 o'clock. All sonologists who perform fetal cardiac examinations know that the image on the right is far easier to recognize and interpret than the image on the left, even though these sonographic images are exactly identical. Now, going back to FINE and the diagnostic planes, remember that there is automatic reorientation and standardization of the anatomical position. Specifically, the fetus and diagnostic planes are consistently displayed in the same manner each time, regardless of the fetal position or initial orientation. This allows fetal structures, anatomy, and relationships to be more easily recognized as normal or abnormal. This is accomplished in three ways. First, a true breech presentation is automatically converted by FINE to a vertex presentation during the marking process. Second, the fetal spine is always automatically placed by FINE at 6 o'clock. And last, the orientation of cardiac diagnostic planes is standardized. First, let's talk about breech presentations. FINE is able to recognize during the marking process that the fetus was in a breech presentation when the stick volume was acquired. Therefore, FINE can automatically reorient the volume so that the fetus is now in a vertex presentation. This is done through a breech alert, which has already been reviewed in a separate lecture in this series. Why convert a true breech presentation to a vertex presentation in FINE? Marking of anatomical structures is easier and consistent, since structures will always be in the same location on the screen. Another reason is that fetal structures and anatomy are more easily recognizable by users. For example, with a breech presentation, the cardiac apex will point to the right side of the screen. However, when the same fetus is in a vertex presentation, the apex will point to the left side of the screen, and this is the image most familiar to sonologists. Here is an example of how this is done. Notice that one has to scroll to the other end of the stick volume to locate the stomach, and this is because the fetus is breech. Once the aorta is marked, a breech alert will appear, and after clicking yes, FINE will automatically convert the breech to a vertex presentation, and the marking process will continue, with the next structure to be marked being the aorta at the level of the four-chamber view. Regardless of the original fetal spine location in the stick volume, FINE will always automatically place the fetal spine at 6 o'clock for the diagnostic planes. As an example, here is a fetus in which the original spine location in the stick volume is between 7 and 8 o'clock. This is the same fetus shown in stick loop. Please note that shadowing is evident. When the diagnostic planes are generated by FINE, the fetal spine will always be placed at 6 o'clock automatically for all 9 views, as shown here. This allows fetal structures, anatomy, and relationships to be more easily recognized as normal or abnormal. Notice that any shadowing artifact in the stick volume due to fetal spine location or other reasons will still remain. We have designed the FINE method so that the orientation of cardiac diagnostic planes is always standardized. This occurs for axial images in which the fetal left is on the left side of the screen. This is indicated by automatic labeling. And the fetal right is on the right side of the screen, also indicated by automatic labeling. Moreover, FINE will place the cardiac apex so that it is pointing to the upper left corner. The longitudinal cardiac diagnostic planes are also standardized so that the cranial end of the fetus is on the left side of the screen, while the caudal end of the fetus is on the right side of the screen. Another characteristic of the 9 cardiac diagnostic planes is that each of them are 4-dimensional images. Although the diagnostic planes appear as if they are a single plane, this is actually not the case. Each cardiac view is a 4-dimensional image. This is demonstrated by this video, in which one can see that each of the 9 cardiac views is not a single 2-dimensional slice, but is actually a 4-dimensional image. This is shown in the 3 vessels and trachea view, the aortic arch view, and finally all the 9 views. The last characteristic of the 9 cardiac diagnostic planes is that successful display can occur despite different gestational ages and in the presence of anatomic variability. The FINE method is not limited to just the second trimester, but can successfully display fetal cardiac views over different gestational ages, including the first and third trimesters. Moreover, a novel and important feature of FINE is that it generates a geometrical reconstruction of the fetal heart that fits the anatomy of each particular case under examination. This occurs despite anatomic variability, such as in the cardiac axis and geometry, making this algorithm adaptive. As a result, there is still successful display of fetal cardiac views with FINE. Even when there are various types of congenital heart disease present, as shown here, fetal cardiac views, which are abnormal, are still successfully generated and displayed by the FINE method. Our team has conducted a study on this subject, and this will be discussed in other lectures in this series. For example, here is a case of tetralogy of Fallot that was analyzed by FINE. 9 fetal cardiac views have been successfully generated and displayed. However, when examining the cardiac views, 6 of them demonstrate the cardiac defects. For example, pulmonary stenosis is shown in the 3 vessels and trachea view, as well as the ventricular septal defect and overriding aorta in the left ventricular outflow tract view. Now we will spend a few moments reviewing the knobology for viewing and assessing the cardiac diagnostic planes. The following parameters can be adjusted: image settings, color tint. The 9 planes in the template can be transformed to a single format, adjusting beats per minute, and adjusting the cardiac phase. Image settings. An important point is that it is strongly recommended that prior to assessing the diagnostic planes, one should adjust the image settings, which are brightness, midtones, and contrast, to increase the contrast quality of the image. This is accomplished by adjusting the slider buttons shown. Here, the brightness has been decreased to -7, the midtones increased to 1.36, and the contrast remains at 0. Brightness refers to the absolute value of color's lightness, darkness. For the fetal heart, adjusting the brightness affects the appearance of the blood pool. As the brightness is decreased, note that the blood pool, such as in the 4-chamber view, will become black. But as the brightness is increased, light colors will become more obvious. Contrast is the distinction between lighter and darker areas of an image and makes objects or details within an image more obvious. For the fetal heart, this will affect the fetal bones, such as the spine. Note that decreasing the contrast will make light and dark areas stay about the same, but as the contrast is increased, light areas will become lighter and dark areas become darker. Midtones. All luminance or intensity of light values that are not dark or light are considered to be midtones. By adjusting the midtones, this darkens or lightens the medium neutral grays. We recommend that when first adjusting the diagnostic planes, in general, start with the midtones first by increasing this. This means moving the slider to the right rather than moving the slider to the left. Color tint. Now, another adjustment that can be made to the diagnostic planes is to the color tint by clicking here. There are several color tint maps that are available and are chosen based on user preference: sepia, gray, and ice. Here are the diagnostic planes with the sepia color tint, gray color tint, and finally an ice color tint. Fine allows each of the 9 diagnostic planes to also be displayed as a single image only. This is accomplished by pressing the button labeled Format. The button shows a single template of 9 planes that is interchangeable with only a single cardiac plane. In this example, the user chooses the cardiac plane of interest by clicking on it. Here, it is the left ventricular outflow tract. Next, click on the Format button and the single cardiac image appears. If one clicks on the Format button again, the 9 diagnostic planes will be shown together. Once the single cardiac plane is shown, if one wants to view the other planes one at a time, this is accomplished by clicking on the drop-down button, and all 9 diagnostic planes are listed as shown here. Click on any of the planes, such as the ductal arch, and this will now replace the left ventricular outflow tract image. Fine allows one to also adjust the cardiac beats per minute. The default is always set to 60 beats per minute. We did this on purpose because this is a comfortable heart rate to view and assess the cardiac diagnostic planes. However, the rate can be adjusted all the way from 0 to 300. Moreover, if one desires, by pressing this BPM estimated button, this changes the default fetal heart rate from 60 beats per minute to the original heart rate when the stick volume was acquired. In this example, the fetal heart rate was 153 beats per minute when the stick volume was acquired. Finally, Fine allows one to adjust the cardiac phase. When this panel is shown, the fetal heart in the diagnostic planes is in motion at 60 beats per minute. By pressing this button, this will freeze the diagnostic planes so that the cardiac phase can be adjusted. At the same time, the panel will convert to the one seen here. By sliding the gray button to the left or right, the cardiac phase in the cycle can be adjusted, for example, to systole or diastole. In conclusion, Fine automatically generates and displays 9 fetal echocardiography views, and we refer to this as diagnostic planes. Diagnostic planes are displayed simultaneously in a single template, showing both transverse and sagittal planes. Fine is therefore not equivalent to tomographic ultrasound or multi-slice imaging. Diagnostic planes may be viewed in motion or as still images. Automatic realignment of stick volumes and reorientation and standardization of the anatomical position occurs. Each of the 9 cardiac views is a 4-dimensional image. Successful display of fetal cardiac views can occur despite different gestational ages, as well as anatomic variability, for example, in the cardiac axis or geometry. And we reviewed the knobology of diagnostic planes. Thank you for your attention.